Okay. So expect your grades back Friday night in the evening, usually late. And then you'll hear from me if your KGA is under 78 or if your exam was under 78%. Okay. Let's hop into Canvas. I want to go over what we have due for you guys this week. Okay. This week, what we have due. So we're in week 4 now. We did our exam. You guys have discussion post number 2. Okay. Your initial response needs to be in by tonight at midnight. And then you need to have your other 2 response to your peers done on a different day, but submitted before Sunday night at midnight. Okay. Your other assignment that's due is your SIM chart postpartum hemorrhage. To access your SIM chart, you're going to click into the SIM chart under your module, and it'll pull up this load SIM chart in a new window. And then you'll just follow that, it'll take you to Evolve. Okay. Remember that if you still have not submitted your NCLEX questions or if you still have not submitted your SIM chart infection assignment from last week, those are still available to be submitted. They would just have that 10% late penalty. Okay, you can submit those by Sunday. So if you're don't miss out on your points for your homework. So if you wanted to still complete some stuff from week 3, you still can. You can turn it in, and I will give you late credit. Okay. Does anyone have questions about that or about what we're doing this week? Okay. Mackenzie, can you turn your screen on for me, please? Okay. We'll give her a second to come back in. So this week we're going to be talking about postpartum care. Um, I would really encourage you guys to listen to the lecture. I know that it's an additional almost 2 hours of class time. But in class, all we're really focusing on is our big picture items. We're not breaking down things into the extent that you need to know them for your exam. So the lectures are there for you um, in order to give you all the information you need. Class is meant to be more of a review, okay? So definitely from this point, especially like if you scored poorly on the exam, read, listen to, and take notes on the lectures because that has the bulk of the material that you need to know, okay? Last semester, I lectured the entire class time, which I think is beneficial in a way, but I wanted it to be more formatted that we could do review and go over things that maybe need a little bit more attention. So that is why I do the recorded lectures now. Okay. Um, and then, like I said, if you did not score the way that you wanted to score on the first exam, reach out to me and we'll go over it and we can meet to go over everything together. Okay. If you guys don't have any questions for me, we're going to spend the next 40 minutes or so on our week 4 classroom PowerPoint. And we're going to go through that. And then if we don't, whatever we don't get to, I know last week and the week before, the stuff that I didn't get to, I just copied and pasted and put in your course cafe. The way the next 2 weeks is formatted, anything we don't get to today in class, we're going to finish up next week. So I'm not going to send you practice questions or stuff for this week. I think after the exam and all the homework that you still have to do, you guys have more than enough that you're working on. Um, but anything that we don't get to today, we will finish out next week. So don't worry, we are going to cover everything. Okay. So let me get my PowerPoint pulled up. We're going to get started. All right, so like I said, this week we're focusing a lot on postpartum care. But first, we're going to spend some time reviewing from last week. So, how do we measure our contractions? Can you guys explain that process to me? Like, what are we looking for whenever we're looking at contractions?
Duration, frequency in between. I mean, not frequency, but you get me, the duration between them and how long they last. There we go.
Yep. Um, so what is our frequency? How do we measure frequency?
How often it's happening?
How often we're having contractions? Yes. So that would be like from the start of one contraction to the start of the next contraction. Our duration, we're just counting that for one contraction, right? So the start of one, the end of one. What else do we need to know about our contractions? This is especially important if we're trying to assess how labor is progressing or effective.
Intensity, I guess.
Yeah,
How
how strong they
often?
are. How strong they are. Yeah. How often? Yeah, definitely. So we're measuring, let's see, frequency, duration, interval, palpation for strength, right? Because our how intense they are, our intensity, you can't measure it in a numerical value unless you have that intrauterine pressure catheter, unless you have internal monitors. If you don't have internal monitors, we have to go by the feel of the mom's belly when she's having a contraction, and that's going to be your mild, moderate, or your strong contractions. Okay. What is important to note with rupture of membranes? What do we want to know?
If there's a ruptured membrane, you mean like the sac the baby's in?
Uh-huh. Like if mom's water breaks,
Hmm.
what do we want to know about it?
If the water breaks, hmm. If it
How
was
Is there any signs of blood?
bleeding,
uh-huh. If she has any bleeding, that's definitely important. Danielle, I think you said color, and that is yes, definitely. Because what is
Is
it? Oh, sorry,
what,
Gladys, what did you say?
the amount that came out?
The amount.
what color should it be?
So typically amniotic fluid is colorless, and they sometimes there's like white specks in the amniotic fluid.
Hmm.
That is from what we call vertex, not vertex, vernix, vernix, which is we call it like in L&D like the cheese. Like we say this baby's really cheesy when they come out because it's like that like white stuff that is surrounding the baby. That can come out, vernix can come out. We just really don't want it to be green. Do you guys know what that means? If a baby has a the amniotic fluid is green,
Infection of some sort?
it can be infection.
No, no,
Meconium?
that's like the poop of the baby. But I don't know.
Is it
Meconium.
meconium?
Yeah, that's
There
when
you go.
exactly. Good job.
Good job.
So our green amniotic fluid can indicate that the baby has had a bowel movement during labor or during when in utero, which what does that usually indicate? If baby's having a bowel movement during labor and we are considering that to be a bad thing, what can that indicate for us?
Probably aspirated it.
The baby has a risk of aspirating it, yes.
I was gonna say that they're in distress.
Exactly. Yes, that's what I was looking for. If you're having meconium stained fluid, that is an indicator that your baby is in distress, that there was something that happened during her labor or during the pregnancy that stressed out the baby that made the baby have a bowel movement in utero. Bowel movements in utero are not normal. We don't want to see that because like you guys said, as the baby is passing down through the vaginal canal, they have an increased risk of swallowing that meconium. And that meconium, I don't know if you've ever seen it or changed a meconium diaper or whatever. It is like that thick, black, tarry substance. So if a baby is swallowing that and they're already trying to convert everything to be able to breathe effectively, that meconium is not going to help us. right? That's going to make it way harder for them to take these first breaths. That's going to put them in distress and can lead to something that we call meconium aspiration. Okay, so that's a danger for the baby. So we want to know with our rupture membranes, what color is it? Is there a smell? So you guys had mentioned infection. If we are suspecting that mom had an infection during her labor or during her pregnancy, um, one of the things that can indicate that is if her amniotic fluid has an odor to it. Okay. Does anyone know the name or the medical term for an infection of the amniotic fluid? This is we're getting ahead a little bit. It's called
Is it chorioamnionitis, something like that?
yes, you got it. I can't say that word really well either. It's chorioamnionitis. Choreo, the way that we see it, obviously, we're going to diagnose it via like a culture or a test to see if there was an infection present. But choreo has a very distinct scent. Like it's like C. diff. It doesn't smell like C. diff, but everybody kind of knows what C. diff smells like. There's a known scent for that. Choreo is the same way. Like if a mom has an infection of her amniotic fluid, it's going to smell really weird. We need to know how much, right? Because that goes back to our polyhydramnios versus oligohydramnios and what those things can mean for us. And then we also need to know what our baby's heart rate does whenever the membranes break. Because, and this is also like at some added info, but you will want to know this for later in class. When the water breaks and mom has a lot of it, and that baby's head, let's say that baby's head isn't fully engaged on the cervix, what do we think could potentially happen? You have a lot of fluid pouring out really quickly. Your baby's head is just kind of floating up in space. What are we worried about with that? Think about your anatomy.
Trying to work through this. So when the fluid's gone, baby's no longer floating, correct?
There should still be a little bit of fluid. It doesn't all the way just like completely empty out and then the baby's like chilling with nothing. Babies are continuously producing amniotic fluid. Um, but if we think about it, you have your amniotic sac, you have your baby in there. What else is in there that's just kind of floating around with the baby willy-nilly? We don't really know where it is.
The
We don't want it to come
placenta.
out first.
Linda?
The placenta, but there's one other one that is more of a with
The
the
umbilical cord.
umbilical cord. So one of the biggest things that we see with ruptured membranes, especially if the mom has a lot of fluid and that baby's head is not engaged, we see that cord just slip under the baby's head and it comes out first. And then we're going for a stat C-section. Okay. So if a provider comes into my room with my patient, and this patient is a gestational diabetic, she has polyhydramnios, which is a very common thing to have with gestational diabetes. And she's only 1 centimeter. We can't feel that baby's head. And that resident says, I think I'm going to break her water. I'm going to say, I don't think you're going to. And that is why we don't want a cord to come out because then you just completely ruin this woman's chances of having a vaginal delivery, right? We're immediately going to have to go back for a C-section. All right, what are the 5 P's that affect labor?
The
Passenger,
passageway,
passenger, powers,
Mm-hmm.
position,
Position.
cycle.
You
So
guys, yep, you got it. You got it. Passenger, passageway, power, position, psychologic response. Good job. What would the nurse do first when noticing abnormal fetal heart rate tracing? If, like, say we have a late or a variable decel.
Change position.
Yeah, we're going to want to reposition the mom. Exactly. We want to get that pressure off of the umbilical cord, right? Cord compression. What are our four stages of labor?
The first one is dilation and the delivery of the baby. No, it's just the dilation of the cervix, right? The second one is delivery of the baby. The third one is the delivery of placenta, and the fourth one is the recovery from the mom.
Yes, awesome. So your first is your dilation, your second is the pushing and delivery of our baby, third is our delivery of the placenta, and fourth is our recovery period 2 hours after birth. Great work. A mom is 10 centimeters dilated, she's pushing, and she's feeling burning in her vaginal area. What could the provider administer to decrease sensation to the vagina and perineum as the baby is being delivered? This kind of goes into your meds.
I can't think of the name there.
I don't remember the name, but it was a medication that it goes into the cervix and like numbs it, all of it. And it's like after, if you don't have enough time to get the epidural, they give you that if you're in like a lot of pain.
You got it. It's a pudendal block, nerve block. So this is a nerve block that basically just goes deeper into the tissue, the muscle to numb almost the entire cervix, a lot of the mom's pelvic area, to make her a little bit more comfortable for delivery of the baby. Sometimes we can refer to it as a saddle block, meaning it's just going to be numbing her from effectively like waist down. This is something that the provider can administer for during a vaginal delivery. To be completely honest, I have not seen these very often. They're very rare typically. So we don't use them as often, but yeah, this is a pudendal nerve block. Which decelerations indicate uteroplacental Oops, sorry, did someone have a question? I think. All right. Um, which D cells indicate uteroplacental insufficiency, and what should the nurse do?
Late decelerations.
Mm-hmm.
And you reposition mom, you gave IV oxygen.
Yep. Correct. Definitely.
And I don't know what else.
No, that's perfect. So we have our late D cells. What else could sometimes indicate uteroplacental insufficiency? What other decelerations?
Late decelerations.
Mostly it's just our late D cells. Sometimes, which I didn't know if this was going to be on here, sometimes if we see increased amounts of variable decelerations, that can show that we're having some uteroplacental insufficiency. But for the most part, the biggest one is our late decelerations. And we can remember our mnemonic SPOILT for our interventions for these because these ones are the worst ones that we're going to see usually on our chart. Okay. So we're going to stop our Pitocin. If you're giving the mom Pitocin to give her extra contractions and she's having late decelerations, the first thing we need to do is turn that medication off. We should not be giving that med if our baby is in distress. We need to change mom's position, administer her oxygen, which to administer a mom's oxygen in L&D, we give them 10 liters via non-rebreather face mask. We're going to open up our fluid wide and give her lots of fluid. We're going to treat any low blood pressure, which can be caused by our epidural. So we see that a lot. We see hypotensive periods or episodes if moms are getting epidural pain medication. And then we can administer tocolytics to stop our contractions if needed. We also, thrown in at the end there, is we need to call our doctor. If you're doing all of these things, you really need to make sure your physician knows about it, right? So, usually, as a bedside nurse in the L&D, you have these standing orders already in your labor and delivery order set. So, like giving a fluid bolus and administering oxygen and changing your Pitocin dosages are something legally that nurses are allowed to do. without necessarily contacting a provider before doing them. We just need to always make sure we're contacting our doctor to update them why we did them and when we did them and how the patient is doing after our intervention. Okay. So, what should the nurse do prior to an epidural to decrease the risk of a common complication? What's our common complication? We just kind of said it.
Hypertension.
Hypotension, yes, exactly. So, what would we want to do before giving an epidural to help reduce the risk of that?
Is the reposition of mother.
What else can help bring up a blood pressure? We can give her IV fluids. So, usually if a mom says that she's going to want an epidural, the first thing that I'm doing is I'm going to start an IV bolus. We're going to pre-bolus her for the epidural. Okay. That's going to decrease her hypotension risk drastically. Some anesthesia providers won't do an epidural until they know a mom has had a full 500 ml bolus beforehand. So if a mom first comes into the L&D suite and she's like 6 centimeters dilated and she's like, I need an epidural right now, we still need to get labs because we need to see what her platelet count is. And we also need to give her a bolus to make sure her blood pressure doesn't drop on us. Name 3 non-pharmacological pain management techniques that the nurse can teach the laboring woman to use.
Visualization,
Visualization, yeah,
breathing techniques.
definitely.
I don't know the third.
See, there's a bunch. So massage, touch therapy, effleurage. Sorry, I can't say that word either. Ambulation, hydrotherapy, abdominal breathing, modified paced breathing, relaxation, and position changes. There are a lot of things that bedside nurses can help laboring moms with, as far as pain management, non-pharmacological pain management specifically. Okay, so these are all things that we should educate our patient on and also help them with if it's something that they're showing interest in. What symptoms may differ with false labor versus true labor?
Like you mean like the Braxton Hicks?
Yeah, so Braxton Hicks
Braxton.
are during which kind, false or true?
False.
Yep. So our contractions can be different with false labor versus true labor. What else?
The location of the pain.
Sometimes pain location can be different in false versus true labor. Let's see. Contractions are going to decrease in intensity and frequency or decrease with activity, and our cervix does not change. Even if a mom is having regular contractions that are palpating mild to moderate, if she does not make cervical change and she stays only like 2 or 3 centimeters, she is not in labor. What we consider labor to be is a progression in cervical dilation and effacement. Okay. Any questions about this review? I'm sure this feels kind of like taking your guys' exam again. But these are all really good things to even keep up with so that you guys are prepared for your HESI. All right, we're going to jump right into a case study that we're going to work on for this week. All right, so the patient is a newly delivered 2 hours post-precipitous delivery. What does precipitous mean?
Fast delivery.
A really fast delivery. Yep. Of 4 pounds baby girl. That was a small baby. Her vital signs have been within normal limits. The OB nurse reported that her fundus is firm at midline and 1 finger breadth below the umbilicus. Quantitative blood loss is 500 mLs up to this point. The patient's peripad was changed 10 minutes ago with a moderate amount of lochia rubra. The oncoming nurse enters the room and the patient states, I feel so cold and tired, I just felt a gush down there. So, we're going to be assessing this mom, okay? So what would we see What is concerning, what is not about that, which I can go back to that previous slide if you want to. That might be helpful.
She said she felt the gush,
Mm-hmm.
so we'd be concerned that she's hemorrhaging.
Yes. Let's go back to this page here. So what here stands out to you guys? Based on this fundal exam up here, is that normal? Is that a normal fundal exam?
It's not supposed to be firm, is it?
It is. This is a normal fundal exam. So this, as far as a 2-hour postpartum mom, we want our fundus to be midline. We want it to be firm. If it's not firm, that means that your uterus is not properly contracting and you're not expelling and it's not preventing any hemorrhaging. So this up here is a perfectly okay fundal exam. What about her blood loss? This mom delivered vaginally. What is our limit that we usually see with a vaginal delivery? What do we not want it to go above? We want for a vaginal delivery for it not to go above 500 mLs, really. Okay, so she just had a vaginal delivery. She's at that 500 ml point. Okay. Her pad was changed 10 minutes ago with a moderate amount of lochia rubra. So this was only 10 minutes ago, and she just said that she's feeling cold and she felt a gush down there. That's not a very long amount of time in between the last fundal exam, right? So going back to this question, we said that she's at a risk for hemorrhaging because she felt that gush. We went over the concerning stuff. So, our normal findings is going to be blood loss less than 500 mLs for vaginal delivery, 1,000 mLs for C-section. Okay. So our fourth stage is the stage that we're in right now. We're in that recovery period with that mom. So like we said, she's kind of at that brink with that 500 mLs of that vaginal delivery. So even her losing more in the postpartum period is going to put her over into what we would define as a postpartum hemorrhage for vaginal birth. We do want that contracted uterus or that firm fundus. So let's get to our concerning findings. If she's saturating more than 1 pad per hour, if she's having any large clots or a lot of very small clots, and then signs of uterine atony. So uterine atony is that boggy fundus. Okay, that's when we get concerned for postpartum hemorrhages. That's when we're worried about moms bleeding way too much. We want that fundus to be nice and firm. If it's a boggy fundus, that's going to increase the mom's risk of bleeds. Any type of sign of unrepaired laceration. So if you do a fundal exam and you feel that mom's fundus and it's really nice and firm, it's right in the middle of her belly, it's right below the umbilicus, it's not distended or anything crazy, but she still has like a dark or red trickle of blood from her perineum, odds are that's coming from a laceration that probably should have been repaired but was not in the postpartum period. Okay. So we need to be assessing her perineum every time we do a fundal exam. We also need to see if she's displaying any signs of a hematoma, which would be if mom complains of that intense perineal pain, if she's having some swelling, if there's like blue-black discoloration of the perineum. On my lecture that I recorded, I put a lot of like really awesome, I guess, pictures of hematomas that you guys can reference if you would like to see what that can look like. And then also we're wanting to see if mom is going to be going into hypovolemic shock because of blood loss. Is she dizzy, lightheaded? What are her vital signs? Is her blood pressure low and she's tachycardic? Is she acting confused or disoriented? She's very pale, not very having very much output, cool and clammy skin, right? Those are all signs of mom going into that hypovolemic shock. So we need to keep close eye on this mom, especially if this lady, she just complained of feeling cold and she complained of feeling a large gush from her vagina. There's a scary picture for you. I do not like that picture. All right, so what's our priority if a mom is bleeding?
Administer IV fluids?
So we're going to give her fluids because we don't want her blood pressure to go too low because she's losing a lot of blood, right? What is our number one priority if a mom is having a hemorrhage?
Did you have to have more blood product?
We could give her blood, but what do we need to correct first?
Stop
Stop
the
the bleeding.
Stop the bleeding. Yeah. So we need
bleeding.
to figure out, is this coming from the fundus? Is this coming from an unrepaired laceration? Where is this bleeding coming from? Okay. If it's coming from the fundus, is it because we have retained products? Is there tissue sitting up in that uterus that's not allowing that uterus to clamp down and in making our uterus boggy, and we're not expelling our clots all the way? Okay. Um, so you guys kind of hit some things. We're gonna maybe give some fluid, maybe some blood products, but we want to stop the bleed. So this might seem kind of like a simple question, but how do we know that it worked? How do we know that our interventions have worked?
So stop bleeding.
She'll stop bleeding. Yeah. She's going to stop having bleeding. Her fundus is going to be midline. It's going to be firm. It's not going to be boggy anymore. Her vital signs are going to improve. She's not going to be showing signs and symptoms of hypovolemic shock. Okay. So the first step is we need to consider that cause. Like I said, where is this bleeding coming from? Okay. We need to assume that it is uterine atony unless proven otherwise. Most of the time, if a mom is bleeding postpartum, it's because her fundus or there's something going on with her uterus that is causing it to have uterine atony. Okay. So we're going to check our fundus. We're going to administer a Foley. Why would we want to administer a Foley when we're talking about uterine atony?
So does she not need to get up and move around much?
So it is a safety thing, right? Because if mom is feeling kind of dizzy and disoriented, we aren't going to want her out of bed. But from an anatomy standpoint, think about atony, uterine atony, think about bladder. Why would we want her bladder to be empty?
To prevent an UTI?
Well, she is at a high risk for UTI because of her bleeding, but that isn't the priority why we're inserting a Foley in this case. So let's think about it. So you have your uterus, which just had a huge baby in it, and now it's trying to shrink back and go back to its pre-pregnancy state. You have a bladder that's full and it's pushing up against that uterus. Is that uterus going to be able to accurately contract down and clamp down and be firm if that bladder is kind of in its way?
No, you need to have your bladder empty, basically.
Yeah, your bladder needs to be empty because a full bladder is going to displace your uterus, and a displaced uterus is going to be a boggy uterus, and that's going to lead to mom hemorrhaging more and having more bleeding. So that's why we want a Foley catheter, okay? That's actually one of the first things that I will do as a bedside nurse. If I see that my mom, and this is like a couple hours after delivery, immediately after delivery, if they're hemorrhaging really bad, we're not going to put a Foley in immediately. But like one time I had a lady who I had her and she was postpartum for like 12 hours. And she just started throwing clots and clots and clots. Like I went into her room and she was sitting in a pile of blood. Like she looked like that big scary picture. And the first thing I did was did a fundal exam, and her fundus was moved off to the side. And if it's moved off to the side, most of the time that's because the bladder is in the way. So if your fundus is off one way or the other, it's because that bladder is in the way and blocking where it needs to be. So I felt her fundus. Her fundus was displaced to the right, and it was super high up on her, past her umbilicus. So I inserted a red rubber catheter, and I pulled 1,500 mLs from her bladder. And immediately her bleeding stopped, and she went about business as usual. But we need to make sure that that bladder is empty because it can cause that uterus to be displaced, and it can lead to the mom bleeding more. Pitocin. We want to administer Pitocin. Why? What is our
Cause
Pitocin?
the uterus to contract.
Yeah, exactly. So during labor, we only give a small amount. During postpartum, we give a bolus of a lot of Pitocin. Okay. And that is basically just to make sure that that uterus clamps down. It is something that causes the uterus to contract. We are going to massage our fundus. So someone explain to me what a fundal massage looks like and how you should perform one.
Would you like massage on the top part of their stomach, kind of like by their umbilicus?
So you'd want to put one hand on top of the fundus, which you can feel, like you can feel it in a pregnant mom or postpartum mom, the top of where that uterus is. So you'd have one hand there. Yep. What else do we do?
Towards the bottom part of like their symphysis pubis, maybe?
So the bottom of the fundus. We're going to have our other hand on the bottom of the fundus. Why do we have our hand down there?
Mm.
We have our hand there to prevent uterine prolapse or uterine inversion. We have our hand there to support the fundus and also to just add more contractility as you're performing the massage. So what you would do is you would have one hand on the top of the fundus, the other hand supporting the bottom of the fundus, and then you would just basically make a circular motion and massage that uterus. Okay. The massaging action is going to cause any blood or blood clots to expel from the uterus and cause the uterus to contract and firm up. Okay. So that's why we want to massage the fundus because we are basically helping that uterus get to a point where it's expelling the bleeding, and eventually we aren't going to have to do that. It's going to just maintain its contractility. But until then, we need to help in the process because there's a lot of blood that can form that we need to get out.
So can you repeat that sentence? Keeping the hand there to prevent the uterus from.
To prevent the uterus from inverting. So like pushing it completely out.
Gotcha.
Yeah, that's pretty much, and just like supporting to also add even more contractility to your vaginal massage. We talked a lot about why we would want to manage our bladder. So our uterotonics that we're going to use a lot in the postpartum period if mom is having bleeds would be our Pitocin, right? Our oxytocin, because that causes the uterus to contract. Methergin. When are we not going to let moms have methergin? When is it contraindicated?
Asthma. Asthma?
What was that? I'm sorry, Linda, I couldn't hear you.
Is it asthma?
So that is Hemavate. You're on
okay.
the right track. You just slipped them.
High blood pressure?
High blood pressure. Yeah. Yep. So if you are going to give mom methergin, which is another medication that can increase the contractility of our uterus, cause the uterus to be firm, we do not want to give that to any mom that is having high blood pressure because a side effect or an adverse reaction with methergin is elevates your blood pressure. Okay. Another one that's very common is misoprostol, which is also Cytotec. Cytotec causes that uterus to clamp down. Basically helps keep the uterus nice and firm. A typical postpartum dosage of methergin is going to be 1,000 micrograms administered by the provider. Typically, it's rectal, like a rectal dose. Cytotec is something that causes moms to have any of these medications really can cause moms to have a lot of cramping and discomfort. Cytotech is a really big one that can cause moms to have cramping and discomfort. So we need to monitor our moms and make sure that they are comfortable, especially after giving them 1,000 micrograms. Like that's a lot of Cytotech. Okay. So Linda said our Hemabate, it's contraindicated in anybody that has asthma. Okay, so we cannot give asthmatic moms Hemabate. Okay, so these are your main uterotonics. I talk about them in a little bit more extensively in the recorded lecture. There's also a huge table in your textbook that goes through why we're giving these meds, the dosage, the timing, all that stuff. Okay, so please review those things on your own. So if mom is bleeding, we're also going to want to have IV access. We want 2 large bore IVs, okay? Because we are most likely going to have to give this mom blood if she's hemorrhaging, and nothing is compatible with blood, right? Except saline. So we need our 2 large bore IVs if possible. She's extremely hemodepleted, so we are going to have a hard time getting another large bore IV, but we need to try our best. We're obviously going to monitor our vital signs and administer oxygen, and then IV fluid and blood products because we need to maintain tissue perfusion and we need to maintain mom's blood pressure, right? So all of these things, as far as postpartum hemorrhage, this is the stuff that we need to be thinking about. These are things that we need to be doing. Obviously, if you are this patient's bedside nurse, you are going to want to phone a friend, right? You're not going to want to be in this room by yourself when this mom is actively bleeding. Because I've been in postpartum hemorrhages before where moms are constantly bleeding to the point that there's one person providing continual fundal massage while the provider is in the room working or administering meds, and there's another nurse who's giving oxygen, who's getting vitals. So this is like a all hands on deck situation because hemorrhages can progress very quickly. So how do we know that it worked? We have a firm fundus, we have decreased bleeding, and mom's vital signs are improving. So all of those interventions can spell out a really fun mnemonic motive. So M, medications, call your MD, oxygen, tone. So we want to massage our fundus if it's not firm. If it is firm, then what is our source of bleeding? IV, we need our second large bore. Vital signs, empty her bladder. All right. So Alyssa, age 26, had a C-section 7 days ago. Sorry, hold on. And is breastfeeding her baby. She calls the office today and reports that she has a temperature of 102.4. What could be the cause of Alyssa's fever?
Could it be that she's getting an infection somewhere?
Could be. She could be developing an infection. These are some things that we can be worried about. Endometritis, mastitis, cystitis, or a UTI, or an incisional surgical site infection.
Bronchitis.
Yeah. I accidentally clicked ahead, but what additional questions do we want to ask her to try and ascertain the cause of her fever? We want to know how long she's had it, right? If this is a new onset, that can help us pinpoint what exactly could be causing her fever. Has she had any pain or burning during urination? Because that could indicate she has a UTI. Has she had any pelvic or abdominal pain? Any breast pain or tenderness? What does the vaginal discharge look like? Does the discharge have an odor? And then is there any redness or drainage at the incision site? So all of these questions here are basically trying to determine out of these 4 things up here, which one is she, where is this infection coming from, right? So endometritis has she had any pelvic or abdominal pain? Any breast pain or tenderness is going to go to mastitis. What does her vaginal discharge look like? Because that could also go back to endometritis. Does the discharge have an odor? Any redness or drainage at the incision site? We're obviously worried about an incisional infection. Okay. What other things can moms have with an incisional site infection? Besides like redness or drainage at the incision site.
Like inflammation?
Inflammation.
Maybe pus.
Some pus could be, yeah, definitely. She's gonna have those like flu-like symptoms, right? So she has the fever. She's probably gonna have body aches or chills. She might have like redness. That incision might be warm to the touch. She might be to the point again where it feels like she just had her surgery. Like she feels like she can't get up and walk around normally. Okay. 7 days postpartum, she should be up and moving pretty easily at that point. So if she's regressing, that could be a sign of an infection as well. Okay. So with these four things, what I want you guys to know for the purpose of your exam, I need you to know what each of these are, what the common signs and symptoms are that are associated with each one, and what the normal course of treatment is or what providers typically recommend. That's what I want you to know about these four things for your exams.
Do we have this anywhere?
So I go over it in my recorded lecture.
Okay, gotcha.
And then if not, it's in your text. But I do talk about them. But I can, but I do talk about them a lot in the recording. All right. So, with this mom that has the infection, what would we see? What is concerning and what is not? So, if she has a fever over 100.4 postpartum day 2 through 10, that could be concerning. We just saw it. The first 24 hours would not be diagnostic. Fever, lethargy, or tachycardia are some things that we'd be concerned about because that's all going to indicate infection. So here's these things broken down. So endometritis, we're going to see the foul-smelling discharge. A mom is going to have a tender abdomen and subinvolution. So her uterus might not be firm. She might have some bleeding again. It just might be a little discombobulated. With mastitis, that is that unilateral breast redness. So that is the infection of like the milk ducts in the breast tissue. So we're going to see that unilateral. So the one side breast redness, warmth, pain, and then mom is going to have flu-like symptoms. With a UTI, she's going to have frequency, urgency, and burning. And then a perineum and incisional site infection, we're going to see redness, swelling, tenderness, and then occasionally some purulent discharge or just like pus or different color discharge. Okay, so this kind of goes over the main points with each one of them about what you would see. So definitely know that. Okay. What is our priority with these patients if they come in with an infection?
Find the source and then get them on some antibiotics.
Yeah. Administer and teach the use of antibiotics. You guys should know, like from farm, like don't stop your antibiotics for anything. Take it at the same time. Eat it with food or not, Administer and teach the use of analgesics for pain and fever. So educating them on Tylenol to reduce their fever, how often to take it, and why they're taking it. Frequent assessment of a patient's symptoms, right? So we're going to want to be continually assessing these patients because we don't want it to progress to sepsis or anything crazy like that. The education that we're going to give these patients would be maintaining our cleanliness and our personal hygiene. For mastitis, they can use warm compresses and frequent pumping or breastfeeding. Unfortunately, these moms should still continue to breastfeed on the affected side. That is something that you need to know. And they never want to because it's painful, right? Sometimes with mastitis, moms can even have like bleeding coming from the nipple or some like discharge like that. So we still want them to pump. We still want them to breastfeed because it helps draw out that infection. Babies can still nurse on affected sides of mastitis. Okay. For any lacerations or any like tears, we need to ensure proper perineal care. Is the mom using her peri bottle? Is she wiping front to back? Is she changing her pads every 2 to 4 hours to make sure she's not sitting in a bunch of blood? Her surgical site infection, keep it clean and dry, and follow the normal like wound care that the providers tell them to use. For UTI, we're going to need antibiotics, increase their fluid intake, and then proper perineal care as well. Okay. So in educating your patients on these so that they don't have reoccurring infection is extremely important. All right. So I don't want to get into this case study because we only have 2 minutes left. So what we're going to do is next time at the start of class, we're going to finish up that case study and go through the rest of week 4 PowerPoint. I'm going to have a little in-class assignment that we're going to work on where you guys are going to split off into groups, and it's going to be kind of like you're making an educational pamphlet thing for a patient, and then you're going to present it to the class as a group. And then we'll go over our week 5 PowerPoint next week as well. Okay. Let's see what we have next week. We have our quiz number 3 next week. Okay. So please make sure that you guys come to class in time at 2 o'clock. Have your 2 devices. We'll take the quiz right away at the start of class, and then we'll jump into the material. Okay. Your grades will be posted on Friday, but in the meantime, just try and relax and get all your homework and stuff done so that you guys don't miss easy points. Okay. But that's all I have for you today. You guys did awesome. You guys are toughing it out. So good job. Go enjoy the rest of your night.
What what chapters are the quiz on?
So quiz 3 is going to be over content from this week and content from next week.
Okay.
I sent you a email on Canvas.
Oh, okay. I will.
Righty. Thank you, Professor. Have a good day.
Have a good
Have a
night.
good week.
Have a good week, everyone.
You too.